Good evening, everyone. Thank you for joining us on a Friday evening to participate in this workshop. We have our presenter today, Miss Sahiti. Sahiti is a PhD candidate who is pursuing PhD in clinical psychology. Alongside of that, she has roughly 5,000 hours of counseling experience, and she has been practicing in personal space as well as with children, with school-going children, teenagers, college-going kids, and even young adults. We have Sahiti, who has given her commitment towards working actively with children, teenagers, and their parents on suicide prevention, as well as identifying and managing any repercussions that come with abuse, be it a physical abuse, emotional, or sexual abuse. So, with a very warm welcome, I present Sahiti to everyone here. Sahiti
Thank you
here.
so much. Thank you so much for that warm welcome, Ashrita. It's good to see everyone here. Thank you so much for taking out time and joining. As Ashrita said, on a Friday evening, I understand. Thank you so much for that commitment. I'll start sharing my screen.
Yeah.
Is my screen visible to everyone?
Yes, Sahiti. It's load. Yes, now it's this.
Okay, now, as we all are aware, the topic for today's webinar is understanding suicide. What is suicide? And we'll start understanding, the terms related to suicide and what can we do as mental health professionals, what can be done in a school setting, so on and so forth. Now, um, okay, so since this topic is a very sensitive topic where I would say overwhelming information will be given to you, you might feel
Sahiti, I
overwhelmed.
think your voice is breaking. Can you please go again?
Am I audible now? Is it clear? Yes,
Yes, yes,
it's the
Sahiti.
fan and the headphones. Now both of them are off. We'll go ahead again. Now, as I was saying, this whole workshop of 1.5 hour, it will contain multiple mentions of suicide, and it might trigger someone. It might feel overwhelmed. So if that is happening, or if you feel yourself sinking down in that emotions, I really suggest you to take time, calm down and come back and join the webinar. And if you feel like you cannot join the webinar after that, that's all right as well. You can always reach out to us if you need any kind of emotional help. You have our email IDs, so you can go ahead. And we are saying this trigger warning because obviously we are mental health professionals, but again, our well being is also very important for us. I hope this is clear for everyone. Now,
Yes, Sahiti.
before we go ahead into the whole statistics and in depth of suicide, I would want to understand, can anyone help me understand what suicide is? How do you define suicide? I really request to keep this webinar.
Act of taking one's own life.
Okay, I understand. Act of taking one's own life. Understood. um Fair enough. And now coming to the whole statistics of suicide, India actually is one of the highest suicide rate in the whole world. Killing ourselves, yes, that is also suicide. And according to data by NCRB, that is National Crime Records Bureau, India, in 2019 there were 381 suicides reported every day on an average. Now, that's just every day. A year contains 364 or 365 days based on leap year or not. Do the math and just imagine how enormous this whole problem is. Now, suicide is actually one of the most prevalent among men than women in India. And I do understand that there is a little bit of stigma around, surrounded with mental health, that only women feel a certain set of emotions, whereas men don't feel a certain set of emotions. But challenging that stigma that we have, the statistics show otherwise. And the highest suicide rate are often observed among individuals ranging between 15 to 29 years. And to our shock, southern states like the Kerala, Tamil Nadu, Karnataka, AP, they have recorded relatively high suicide rates when compared to other regions of India. All this data is taken by different websites that publish statistics of suicide related to India. Now, we'll discuss about a couple of myths and facts about suicide. I really want this session to be very interactive. If you cannot unmute yourself, I suggest you drop your answers in the chat box. I'll be continuously reading the chat box as well. Now, we'll start with each and every single statement that we have. Once a person has decided to die, I cannot stop them. Do you think that is a myth or that is a fact?
Myth.
Okay, it's a myth.
Myth.
Yes, it's a myth. Yes, because as mental health professionals, what we can do is if we are made aware that the person is having suicidal ideations, we can actually persuade them to get help. We can witness the whole suicide story. Now, what is a suicide story? Is being there for a person, understanding why they have taken a decision that they have taken, what has happened from the beginning of the time till this given point of time where they have taken a decision that they would want to kill themselves. That is suicide story. The one main thing that is very important for us to understand is that we have to be there, present for that person. Active listening is very important. And while we are being there with that person, being there in a non-judgmental way, and being there, giving our time to them and making them feel heard and seen, that is one of the main important thing. And now when that is done, we can actually provide the person with a little bit of hope that yes, there may be someone who can help us. Now, this is why this is a myth. Once a person has decided to die, we can still intervene and we can still stop them from going ahead with that act. Now, she was only joking. She wouldn't actually attempt suicide. Is this a myth or a fact?
Myth.
Myth. Anyone else? Would okay, it's a myth. It's a myth. It's a myth. Now, can anyone help me understand why do you think this is a myth? I really request everyone to type your answers there, or you can unmute yourself and speak, or you can raise your hand so that we can unmute you and you can speak. Why do you think that is a myth? Yes, Divya, please go ahead.
Friend or as a psychologist, we may know them for such a long time, and we may not expect them to go to that extent of taking
Mhm.
killing themselves.
Okay,
We may
okay,
think like that.
okay, understood. Thank you, Divya, for that. Neha?
Maybe because they use humor to cover what they actually are feeling.
Yes, yes. Humor is also one of a coping mechanism that we see where I think I would say uh, a couple of people use humor as a coping mechanism to cover what is happening to them, or to cover the pain and the emotional turmoil that they're going through. So yes, no statement related to harming themselves should be taken as a joke. Okay, the next, talking to someone about suicide will plant that idea in their head. Do you think this is a myth or a fact?
Myth.
It's a myth. It's a
Myth.
myth. Exactly. And
Myth.
does anyone need an explanation on why that is a myth? I'm taking that as a no. Okay. Yes. So the one thing is when we talk about suicide with an intention of creating awareness about it and with an intention of preventing suicide, it would actually not plant that idea in the in the person's head that okay, so maybe I have to go ahead and do the act, commit, oh sorry, not commit, sorry, maybe I have to go ahead and take the step of suicide. Now, did anyone observe that I use the word commit and I've corrected myself? Now, we use the word commit when there is a crime. A crime is committed. According to Mental Health Act 2017, suicide is no longer a crime. So, we cannot use the word commit. She has committed suicide. He has committed suicide. That whole statement is not accepted now. even legally that is not accepted. The way that we can use instead of commit, or the words that we can use instead of commit, are she died by suicide, he died by suicide. Okay, are we clear on this? Yes. Yes, Saujanya.
Saujanya, yeah. So it is not a crime, then the police cannot arrest us if they are trying to attempt or do anything like that.
Um, okay. A Saujanya, from my understanding, according to Mental Health Act 2017, what happens is, if at all you are, I mean, if at all a person is a suicide survivor, again, there are two definitions for suicide survivor. One definition is a person who wanted to die by suicide. They have went ahead with the plan of action,
Hmm.
but they survived.
Hmm.
That is one definition of suicide survivor. The
Hmm.
second definition of suicide survivor is, for example, let's say hypothetically, this phone is a person.
Hmm.
Okay, this phone has died by
Hmm.
suicide. Now, I am very close to this phone.
Hmm.
Okay, imagine this phone is my sister. Now, I
Okay.
am a survivor because I am surviving the loss of someone, and I lost that person to suicide.
Okay.
Okay, so these are two examples of two definitions of suicide survivor. Now, why I'm saying
Hmm.
this is, if you're a suicide survivor in the first definition,
Hmm.
you will be, I would say, ma'am, Hindi and English both languages. Yes, yes, Swati, thank you so much. तो मैं ये कहना चाहती थी कि अगर आप suicide survivor है, then what you can do is, I mean, what generally happens is, you will be, I would say, requested to go and get some help.
Okay.
By
Hmm.
what I mean by that is, you will be requested to go and get some help in terms of seeing a psychiatrist.
Okay. Hmm.
Now, for your perspective comes in when a person is trying to die by suicide in a public place.
Yeah.
In that cases, yes, police will come, police will be involved. They will take you to hospital. They will,
Okay.
all the primary will be done, but then they cannot arrest you. They should not arrest you legally. What they
Okay.
can do is they can recommend you to I mean, they can recommend
For
to,
treatment. Ha.
exactly, that is what that can be. Okay.
Okay. Yeah. Okay. Thank you.
Thank you. Okay. The next thing, if my student or friend or colleague dies by suicide, it is my fault. Is it a myth or a fact? It's a myth. It's a myth.
Myth. Hmm.
Yes. Now, why is it a myth? Especially mental health professionals, what we generally feel is that we have to be there, we have to support anyone and everyone who comes to us, right? Now, in terms of school psychology perspective, let's say we have a lot of students that come to us, and some of the students, they do mention that they have suicidal ideations, and we do the needful that is needed. But there are situations where no matter what we do, the person might still decide to go ahead. There are situations where we feel that मैं और थोड़ा करती तो ऐसा नहीं होता, मुझे और थोड़ा टाइम देना चाहिए था, अरे मुझे वो साइन देखना चाहिए था, अरे पर ये तो एक साइन था, मैं क्यों नेग्लेक्ट की. We try to we tend to move into that cycle, not just as mental health professionals, even as general humans also. We tend to go back to that cycle. Now, here, what we have to understand is, as mental health professionals, the one thing that we can do is always be there for that person, support them. Yes, guilt trapped. That's the exact word. Thank you so much. The one thing that we have to remember is, we can do our level best to support someone, but what decision did they take or they decide to go ahead, it's not in our hands. Okay. Now, the next thing. Only those with mental health issues are suicidal. Is it a myth or a fact? Only those with, it's a myth. It's a myth. Exactly.
Myth.
Yes. Yes. Can anyone explain on why this is a myth? Okay. I forgot to mention one house rule. So in the webinars that I take, or generally in the webinars that Health Basics take, There are no right answers or wrong answers. Okay? We are really excited, or we are open to hear what you have to say, what is your perspective. Now, can anyone explain me on why this is a myth that only those with mental health issues are suicidal?
I'd like to try.
Yes, Gulin, please go ahead.
So basically, it could be the heat of the moment also, that maybe a person is not suffering with some mental health condition, but maybe just that they got to know that they might have invested, some money in stocks,
Yes.
and it just crashed. The market crashed. So the person was not in a mental health condition, but the person got to know that he or she has lost money, and in the heat of the moment, they just attempt the
Understood.
thing. Yeah.
Yes, exactly. Now, Gurleen, you have very clearly and in a very nuanced way, you have explained the concept of precipitative factors. Now, when it comes to mental health, or when it actually comes to the whole concept of suicide, okay, we have to understand one thing, that mental health in whole is a continuum. When I say continuum, unrealistic expectations from oneself and others, yes, that is also a reason for someone to go ahead and with the act of suicide. And okay, thank you so much for that. Now, coming back to what I was saying, mental health is a continuum. For example, let's see, for example, that in terms of my social life, I am excellent in mental health, whereas in terms of my relation, I am very bad. I mean, my mental health is very bad. In terms of my career choices, I am bad, whereas in terms of my professional, like my workplace, I'm happy. So, mental health is a whole continuum where it's always ups and downs. Now, the whole goal of a person is to be in a situation where they are thriving, or they're moving towards the thriving state if it comes to mental health. Now, precipitative factor is something that happens that would completely collapse the whole emotional bank that we have, where we do things to fulfill, we keep on filling emotional bank to keep us happy on a daily basis. One such example of a precipitative factor is what Gurleen has clearly stated, financial crunch. The other example is diagnosis of chronic illness, divorce, loss of a family member, or loss of a job. Yeah, sudden decisions. Or for students, in terms of school psychology, school counseling related, or school psychology related. I also can think of precipitative factors like टीचर ने सबके सामने डांटा, एग्जाम्स में कम मार्क्स आ गए, स्पोर्ट्स में सीट मेडल नहीं मिला. All these are precipitative factors which, for explaining it to a layman terms, we name it as in the moment of heat. Okay? Yes, peer pressure, parental pressure, all of them combine to precipitative factor. Now that we are talking about peer pressure and parental pressure, let us discuss about the biopsychosocial model. Now, sorry, in 1977, George Engel, he proposed a biopsychosocial model which states a mental health is a result of many forces. They're occurring at different times, which have a very cumulative effect of on the individual. Okay, now these forces, they can be positive or negative. Now, if the force is in terms of a negative, then the outcome would be where the person's mental health is effective it's affected. Okay, now here, if the negative outweighs the positive, then a person could develop a mental illness. For example, biological, we'll just think, discuss about biological aspect. Biological aspect can also include, genetic disorders, or diagnosis of a serious illness, or hormonal issues, all of that. Are we clear on this?
Yes, yes, I did.
Thank you. Thank you so much for that. And these come under biological things, like it can also include family history. Yes, exactly. The rest that we take, because the nutrition that we have, all these come under biological aspects. Coming to social health, that is social aspect, the environment that is there, the support that we receive, the life events that happens, the workplace, the sense of safety, sense of belongingness, all of that, all of these, they come under social aspect. Coming to psychological aspect, coping mechanisms, coping skills, the thought that we have, the feelings that we have, the belief system, the core beliefs, the image of self, the perspective of self, self awareness, all of these come under psychological aspect. Okay. Now, this is about the biopsychosocial model, where every single thing should be balanced, or every single domain should have a positive outcome for the mental health of a individual to be good, on a thriving state. Okay. Now, oh, causes of suicide. Okay, now we might say that the person died by suicide because they lost their job, right? But it is very important for us to understand that the whole causes of suicide are multifactorial. We cannot pinpoint to one single reason saying, okay, the person has died by suicide because they were diagnosed with um, cancer. We cannot say that the person has died by suicide because they lost their job. We cannot pinpoint that. The whole concept of suicide is very complicated, that with a very great difficulty, researchers have divided the causes of suicide into six factors. That is multifactorial, where biological. Now, biological as in decreased serotonin in brain, or structural adequacies, or physical deformity, or physical illnesses, or physical disabilities, so on and so forth. Coming to environmental factors include okay, loss of a loved one, a traumatic experience, exposure to violence. It can be any kind of violence, any kind of abuse. It can be domestic violence or societal violence, or yes, how a person is taking the adversity. Yes, tolerance level, that comes under mental health factor. That's a nice point. Thank you so much for that. Now, precipitative factors, as we have just discussed, precipitative factors are negative life experiences. It can be divorce, it can be loss of a job, it can be loss of prestige, it can be financial crunch, it can be relationship struggles, it can be academic struggles, it can be professional struggles. All of these, they come under precipitative factors. Now, coming to mental health, the coping mechanisms that they have, the coping skills that they have, the self awareness, the whole core belief, the tolerance level, the resilience, all of that, they come under mental health. Now, here is a one interesting statistic: 60% of people who died by suicide, they have an underlying, I would say, underlying and undiagnosed mental illness, where with the help of a treatment, they could have got better. Okay. Now, lifestyle, again, proper nutrition, lack of proper nutrition, lack of proper sleep, drug usage, alcohol usage. When I say usage, in terms of abuse, overuse, alcohol abuse, alcoholism, drug abuse, substance abuse, all of that. Social and cultural factor includes the geographical area that they're staying in, the historical influences that they have, and the societal pressure that they have. All of these combinedly, it is called a multifactorial model of suicide. Are we clear till now?
Yes, yes.
Yes, yes.
Okay, perfect. Okay, some theory is on the way. Now, okay. Emily Durkheim, he's a very pioneering sociologist. He proposed a sociological theory of suicide. In his work, he's done in 1987, if I'm not wrong. Now, according to him, suicide is not merely an individual act, but is a whole. He says that it is influenced by social forces and norms. According to him, he identified there are four types of suicide. One is egoistic suicide, which occurs when individuals feel disconnected or isolated from society, where it means that they're lacking social integration. Okay. And the next is altruistic suicide, which involves sacrificing the whole one's life for the benefit of others or for a greater cause, which is often associated with a very I would say strong social integration. For altruistic suicide, I'll give you an example. I'm not sure if you remember this or not. A couple of years ago, there was a rally going on. Okay, I'm really sorry for taking this example if you're not aware. A couple of years ago, there was AP Telangana division that was happening, right? Now there were situations in both AP and in Telangana where people have burnt themselves for a social cause. AP people, because they want a combined state, they don't want state division to happen. Telangana people, they have done that because they want, a state division to happen. They want to have a different state, right? That is altruistic suicide, where there is too much of social integration. Yes, hunger strikes. Yes, hunger strikes. That is also, again, hunger strikes, if continued, that might lead to that of a person. Yes, that is also one kind of altruistic suicide. Okay. Now, the next thing is anomic suicide. Here, it results from a breakdown of social norms and values, which it leads to a feeling of whole confusion and purposelessness. Okay, this is anomic suicide. The next thing is fatalistic suicide, which arises from an very, very oppressive social conditions where individuals feel very powerless to change their circumstances. One of the best example for fatalistic suicide is people who are residing in red light areas. Okay. Now, coming to the second model of understanding suicide, it is interpersonal theory of suicide by Joyner. Now, Thomas Joyner, what happened is, I'm just sorry, Thomas Joyner interpersonal theory of suicide. It completely focuses on the whole intersection of burdensomeness, and thought belongingness. Okay. Now, perceived burdensomeness, it's like a feeling like a whole liability to others, believing that one's existence creates more harm than good. Okay, that is perceived burdensomeness. The next thing is thought belongingness, which is experiencing a lack of meaningful connection or experiencing a lack of social support, which leads to feeling of disconnected from others, and I also would say feeling alienated. Okay, these are, I would say he proposed that, individuals who perceive themselves as burdensome to others and experience a sense of social disconnection are at high risk of suicide. Okay, now Joyner suggested that the combination of these two factors, along with a whole acquired capability of suicide, it increases the likelihood of a suicide behavior. Okay. Now the whole Joiner's theory, it whole focuses on enhancing social support networks, reducing feelings of burdensomeness, and increasing feelings of the sense of belongingness of a person. Okay, are we clear with these two theories revolving around suicide? Okay, now we'll discuss about suicidal ideations and the stages of suicide. There are two types of suicidal ideations. One is active suicidal ideation and passive suicidal ideation. Okay. Now, coming to active suicidal ideation, um, okay, this refers to the thoughts and the whole fantasies or the impulses involving self harm, or suicide, where the person, the whole, where the individual has a specific plan to on how to go ahead with that, has a very specific plan and a very strong intent to carry out that act. Now these thoughts may involve details like what is the plan, such as what is the method, what is the time, what is the location, and the individuals may will actually very clearly express their intent to end their life. Okay. Active suicidal ideation, it represents a very high level of immediate risk. Some examples of active suicidal ideation look like, see, I have a plan to overdose on pills and kill myself tonight. I can't bear to live anymore. I'm just going to jump off the bridge, or I'm just going to jump off my building. Okay, this is active suicidal ideation. Now, coming to passive suicidal ideation. Passive suicidal ideation, it involves thoughts or wishes of death, mostly linking with desire to not wake up, but there is no plan. There is no intent to act on these thoughts. Okay, individuals who experience hopelessness, helplessness, worthlessness, they experience passive suicidal ideation. Some examples will include, no, I don't care if I don't wake up tomorrow, or I just wish I would disappear, or I just wish some truck would come and hit me, or I wouldn't mind if something happened to me. What's the worst that can happen? These kind of thoughts are passive suicidal ideations. Are we clear?
Yeah.
I have a question.
Yes, Ashika.
Does passive suicidal ideation lead to active suicidal ideation?
Yes, there are situations, or I would say incidences, where passive leads to active. But for passive to lead to active, one of the main thing that should happen or that should occur is a precipitative factor, or diagnosis of. Okay, here is one thing. There are two, I would say, scenarios where passive can lead to active. One is being in that stage of passive suicidal ideations for a long time, because it is very tough to deal with that kind of emotional weight, right? Now, this might lead a person to not, if at all the person do not reach for help, this might lead a person to actually reach a stage where they cannot take it anymore, and it might turn into active. And here the risk that we have is, after turning into active, it is very fast that the person might actually have a plan and then immediately go ahead and carry out the act. This is first thing. This is first scenario. The second scenario is, imagine a person with passive suicidal ideation and a precipitative factor occurs. The only solution that they look at is just ending their life. So they might go ahead and carry on with the act. Okay. Did I answer your question? Was it?
Yes, yes, I do. Thank you so much.
I actually saw someone raising their hand. I'm sorry, I missed.
Yeah, there was somebody who raised their hand.
Was there any other question? Okay. Um. Yes, Divya, you had a question, Divya.
That all the passive ideation will surely go to active, or it may or may not go.
It may or may not. That is the whole difference between active and passive. In passive suicidal ideation, there is no intent. There is no solid plan. It's just there. The whole ideation, or I would say the fantasy of dying, it is just there. There is no intent to go ahead and carry on with the act. Okay. Now, coming to the stages of suicide, we have six. I do understand, ideally we say that the whole stages of suicide is ideation, planning, and autopilot state. But if we dig deeper into the whole realm of suicide, we have six stages of suicide. Ideation is where This is the initial, very, very initial stage. Individual experience suicidal thoughts, fantasies, often triggered by feelings of depression, hopelessness, unbearable psychological or physical pain, despair. The next stage is desire. This is where a suicidal ideation intensifies. It develops into an intent of dying. The next stage is planning, where they sit and plan. Okay, I'll select this method. Okay, for me to carry on with this, I need these items. Okay, now I'm sorry. Next is gestation stage, where individuals may swing in between. Should I go ahead with the plan or should I not? Okay, action. Action is a stage where it involves execution of the plan. Okay, now the next is aftermath. Aftermath is for individuals who survive suicide. Aftermath involves the coping of consequences of their actions, the physical injuries, the emotional trauma, and the impact on their relation and sense of self. Now let's move towards a case study. We have Emily, who is a 42-year-old single mother with two teenage children. She's working as a nurse in a busy hospital. Yes, I'm so sorry. Goodlin, yes.
Yeah, I actually wanted to ask. So, in the last stage, the
Aftermath.
aftermath part,
Yeah.
it is only relevant in those cases in which, after the attempt, the person survives, right? Yeah.
Yes.
Okay.
Yeah. Now, we'll quickly go ahead with the case study. Emily is a 42-year-old single mother with two teenage children. She works as a nurse in a very busy hospital and has been experiencing a significant amount of stress and burnout. Emily recently went through a divorce, which has her left feeling overwhelmed and emotionally completely drained. She has a history of depression and has been receiving treatment from a therapist for the past few years. This is the background of Emily. Okay. Now, Emily's suicidal journey begins with persistent feeling of hopelessness, despair. She finds it difficult to cope with the stressors in her life, including very demanding job, financial struggles, strained relationships. She experiences very intrusive thoughts of wanting to escape from her life, from her problems, ending her emotional pain. She often fantasizes about what life would be like if she were no longer alive, imagining a sense of relief and freedom from her struggles. What is the stage that she is in?
Ideation.
Okay. Okay. Now, Emily develops. Oh, okay. I just realized I've actually put the answer in the question. Emily develops a strong desire to end her life as a means of escaping her overwhelming emotional distress. She feels trapped in a cycle of despair and sees suicide as the only way out of her suffering. Okay, Emily starts researching methods of suicide online, considering various options of ending her life. She feels a sense of urgency and desperation to find solution for her problems, and leading to believing that death is the only way to find peace. The stage that she is in is
Planning.
uh, okay. Okay, yes, that is
Gestation, because the last line says she is longing for escape and then instinctual drive to stay existent. Something like that was the thing.
okay. She feels a sense of urgency and desperation to find a solution for her problems, believing that death is the only way to find peace. Desire. Yes, desire is the state because it is there in the question only. She has a very strong desire to end her life. Okay. Now, coming to the next thing, Emily formulates a concrete plan of suicide. She identifies a very specific method, overdosing on prescribed medication, and begins to gather the necessary supplies to carry out her plan. Okay. Now, Emery, she meticulously planned the timing, the logistics of her suicide, choosing a date, where she'll be all alone at house, not, unlikely to be interrupted by anyone. She keeps her plan a secret from her friends, from her family, fearing, the judgment and their intervention. Which stage she is in? Planning.
Planning.
Yes. Now, After all of that, now Emily is experiencing a mixture of ambivalence, or and certainty about her decision to end her life. She swings between moments of intense despair and, like, I want to do it right now, and very very glimpse of hope, unsure of whether she really wants to go ahead with it or not.
Gestation. I saw the line of this slide last time.
Okay.
That's why I said
Yes.
gestation.
Yes. Okay. This is
Yeah.
gestation.
Hmm.
Okay. Now she struggles with conflicting emotions and thoughts, and grappling with the fear of death and the desire from relief from her pain. Okay. She feels torn between the longing for escape and instructional drive to survive. Now, as Gulin said, yes, this is the line. So, gestational stage is where a person, though they have a plan, they are unsure of if they have to go ahead, or is there a very slightest ray of hope. Okay. Now, Emily executes, her suicidal plan on a very chosen day. She ingests a lethal dose of medication in her empty apartment, intending to end her life and escape from her suffering. Despite moments of doubt and hesitation, Emily follows through her plan, feeling a sense of, resignation and inevitability about her decision. Okay, because she only believes that death is the only remaining option to find peace. Now, which stage Emily is in?
Action.
Action. Yes, action stage. Now here comes the next stage, that is aftermath. Now Emily survives her suicide attempt, and in discovery by concerned a friend, um, who just came to check on her. They have taken her to hospital. Life-saving medical treatment has been given. Now Emily experiences a range of emotions, which includes, but not limited only to, the shock, the relief, the regret, and the guilt of leaving their loved ones alone, the shame that is there, and the perceived sense of doubt on self, the judgment, all of that. Now, from here, what happens is Emily receives a very intensive psychiatric care and support from therapists and mental health professionals. She starts a journey of healing and recovery, addressing the underlying mental health issues that contributed to her, suicidal crisis, and learning healthy coping mechanisms for managing her mental health. Are we clear about all the suicidal stages and the ideations of suicide, the active and passive? Okay,
Yes, absolutely.
thank you so much. Now, suicidal clues and warning signs. Okay, this whole thing is a, I would say, case study discussion where we will understand different clues and warning signs that are there. Now, Sarah, she's a 27-year-old woman who recently graduated from university. Now, she started her first job as a marketing assistant at a very local company. She lives alone in an apartment downtown, and she's been experiencing increasing level of stress and anxiety as the news job is starting. Now, Sarah has become increasingly withdrawn and isolated in recent weeks. She used to enjoy socializing with friends and participating in outside activities, but now she frequently declines invitations and spends most evenings alone at home. She has stopped attending her weekly yoga classes, which used to be a source of relaxation and stress relief for her. What do you think this is? What can we classify this thing as?
Withdrawing from activities which she used to previously enjoy.
Okay, okay, withdrawing from activities, withdrawn feeling, excellent.
Passive.
Isolation.
Isolation, yes. Sarjini, I'm so sorry, I didn't hear you. Hopelessness, okay. All of this, can we call it as the change in behavior?
Yeah.
Are we okay with this change in behavior? Yes. Not enjoying activities, social anxiety, all of that. Now, we classify all of this as change in behavior. That is one of the major warning sign and a clue. Okay. Now, Sarah's friend have noticed, very significant change in her mood lately. She appears more irritable, tearful, easily agitated than usual. I'm so sorry. Even a very subtle setback at work, it seemed to upset her very greatly, and she often expresses feeling of hopelessness and worthlessness. She frequently makes deprecating comments such as, I am such a failure, I'll never be good enough. What do you think this is?
Questioning the self, the worthlessness and
Whilst
hopelessness,
questioning worthlessness, hopelessness, excellent. Um,
and
loss,
again behavioral changes towards others.
okay, behavioral changes towards others,
Sounds
and
like
low self-esteem,
first signs of depression.
mood changes. This is what I've heard, or did I hear wrong?
No, no, first signs of depression.
Yes, first signs of depression. Exactly. Labeling, um, negative self-talk. Can we say that?
Yeah,
Yeah.
negative self.
Negative self-talk, mood changes are there, first signs of depression, all of that. Now, these are also warning signs and they are suicidal clues. Okay. Now, Sarah has been experiencing frequent insomnia, disrupt sleep patterns. She struggles to fall asleep at night, often wakes up in early hours in the morning, very, feeling very restlessness and unable to, get back to sleep. She often complains of exhaustion and fatigue during the day, and she also feels, she further shows the feeling of low energy and lethargy. What is this whole specific thing, or what can we call it? Or coming back to the biopsychosocial model, which where do you think this falls under
Biological.
exactly? And why do we call it as biological here?
It is shown in.
Because now,
I'm so sorry, Vani, can you go first, and Gurleen, you can go next.
Yeah, because it is shown biologically the energy levels gone down and fatigue and all those things comes under
Yes,
physical thing. So it's naturally the biological thing.
perfect, perfect. Gurleen.
I was saying the same thing. Like the symptoms are starting to show in the physiology now. So
Yes, yes, exactly. So, um, lethargically, she's feeling down, physical fatigue, physiological changes, physical exhaustion, sleep disturbances, lack of nutrition, all of these. Okay, all of these, they are also signs of suicide. Sorry, warning signs of suicide. Okay, now Sarah's, her friend has noticed that she has been neglecting her appearance and hygiene lately. She used to take pride in her appearance and always dressed neatly and stylishly, but now she often appears very unkept and undressed. And she has lost interest in activities that used to bring her joy, such as shopping for new clothes and getting her hair done. How can we, you know, how can we call this as, or what can we call this as? No self care.
Depression.
Perfect.
Depression.
Yeah, signs of depression. Yes, no self care. Excellent. And can we also say that there is a,
Social, there she's neglecting that social aspect
yes,
where, yeah, social relationships and maybe her appearance is the main thing. No, that she's not
yes,
giving any importance to that. So it
yes,
comes.
exactly,
There
exactly.
is loss of interest in her otherwise preferred activities, right? There is less
Yes, yes,
motivation towards it. For
yes,
in her instance, it is she took a lot of pride in her appearance, right? So
yeah,
now, if she's doing the opposite, then that shows there is less motivation. To apart from general uh, general lack of self care.
perfect. Perfect, perfect. Low self worth, low self esteem, change in appearance, and lack of self care, and yes, I would also say not respecting the self image that she has created for herself. Does that sound right? Would you be okay if we say that? Yeah, yeah.
Yes,
So
yes.
all of these are all of these, they also come under warning signs of suicide. Now, not interested in things she used to do. Yes, all of these. Now, coming. Okay, what is that? Anhedonia. Anhedonia. Can anyone please?
Anhedonia is the loss of interest. Correct.
Yeah, the lack of
Loss
enjoyment,
of,
lack of
yeah,
self love. Yes, yes,
loss of interest is
yes.
another.
Yeah. Now, Sarah has, she has a very several alarming comments recently that suggested that she might be experiencing suicidal thoughts. She has confided in her friend that she feels overwhelmed by the pressure of her new job and is starting to question whether the whole life is worth living or not. She mentioned feeling like a burden for her friends, a family, and has made a very, very vague statements like, I would want to disappear, I would want to escape from everything. What stage of suicide is this?
Ideation,
Perfect. Ideation.
passive
Yes.
ideation, yes.
Passive ideation or suicidal ideation, all of these, they are warning signs of suicide. Okay. Sarah has been using alcohol as a coping mechanism. Sorry. Using alcohol as a coping mechanism to deal with her stress and anxiety. She frequently drinks a lot at home in the evenings and has started to rely on alcohol, as her tip, I would say. Yeah, to relax and unwind. What do you think this is? Okay. Uh, in the biopsychosocial model, where does this fall?
Under psychological, because it is psychological dependence on substance.
Perfect. Perfect. Oh, I'm having such a good audience today. Thank you so much for answering all of this. Yes, addiction, negative coping mechanisms, right? This also falls under that. Having negative coping mechanisms and, increased substance abuse, unhealthy coping. Yes, all of this. Now, her friends have noticed that her alcohol consumption has increased significantly in recent weeks and they are concerned. Now, in this whole case study, what we have observed are there are warning signs or clues. Now, they refer to escaping strategies. Okay, escape strategies is alcohol use, right? Yeah. Now, the suicidal clues or warning signs, what they refer to is an observable behavioral, emotional, or communications, that may indicate that the individual, sorry, is at a very heightened risk of suicidal behavior. Now, for us, recognizing these signs, what happens is it allows for an early intervention and support. Now, what we have seen, it includes a vast number of clues or warning signs. The other things that also include as giving away prized possessions. For example, I take pride in having my book collection. This is a very true thing. I have 280 books. I never leave a chance to talk about that. Now, I don't give a book to any single person, even if it's for reading. Now, suddenly, if I go ahead and say, Vani, take these books, keep them with you. I am giving away my prized possessions, right? That also comes under suicidal sign or the warning sign. And talking about being a burden to someone else or having no reason to live, having no purpose to live, that is also a warning sign. The other warning sign is a sudden developed interest in spirituality or a sudden loss of interest in spirituality. Let's say, for example, I'm a person who believes in God so much that I go I go to temple every day, I pray to God every day, and all of a sudden I come up and say, there is no God, right? Or let's say, for example, Ashrita is kind of a person. Ashrita, I'm so sorry for taking your name for this. Ashrita is kind of a person who is a atheist to the core, doesn't believe in God, doesn't do any puja, all of that, and suddenly she comes and says that there is God. I believe in God so much. Or using of statements like, would there be a place in heaven for a person like me? or would I go to hell? Or using, in communication, using words like, my family would be better off without me, my friends would be better off without me. All of these, there may be direct clues or indirect clues, but all of these, they come under suicidal clues and warning. Now it is very important to note that, these signs may indicate increased suicide risk, but they are not a very definitive predictors. But then what we should do is, we as a mental health professionals, we have to have this very heightened awareness of these risk factors, and we have to be, I would say, we have to engage in a conversation, and we have to respond very promptly if at all we see any kind of ideation in the person. Yes, did anyone have a question? Yes, talking or visiting people who are not in contact for a long, yes, that also, setting, settling all the personal affairs, or let's say for example, I okay, let's say for example, this phone is a person, and I have fought with this phone, and I am not in contact with this phone for so long, and I suddenly go and say that I'm so sorry, we should not have fought, we should have, I'm so sorry for things that I've done, let it go, all of that, giving away gifts, giving away clothes, all of these are warning signs. Are we clear about warning signs?
Yeah.
Okay, now coming to prevention. Now, suicide prevention, it can happen with gatekeeper programs, gatekeeper training programs. They aim to equip individuals with various settings, be it school, be it workplace, with the knowledge and skill set to identify individuals at risk, and how do you intervene effectively, and how do you, provide, or I would say refer them to someone for help. These programs, they aim to teach participants, on how to recognize these warning signs, how to initiate conversation, how to provide support, how to provide referrals, how to facilitate access, all of that. Now, gatekeeping, it empowers the whole community, or I would say whole the society, to play a very proactive role in suicide prevention. Okay, and screening and assessment, as a mental health professionals, what I'm so sorry, as a mental health professionals, what we can do is, routine screenings for suicide risk in our schools, in within our clients, within our community, which can help us identify individuals at risk and facilitate very very timely intervention. Now, there are actually a couple of scales which, even as a counseling psychologist can use, only to understand if the person is at risk or not, but not to, diagnose. This is very important for us to understand. And some of those, I'm so sorry, some of those scales that we can use are, the Kessler Psychological Distress Scale, that is K10, which involves 10 questions where we ask, the participant or the individual, and we decide, or we try to score if the person is suicidal or not. And the ASQ screening is, ASQ is Ask Suicide Screening Question. It has only 5 questions, where, the most important part of the ASQ is we ask the question directly. Um, Hi, I'll name the, I'll provide you with the scales through mail once this webinar is done. Is that all right? Yes. Now, ASQ is a ask suicide question directly. Now, here, if the client answers no to all the first four questions, there is no need of asking the fifth question. However, if the client answers yes to any one of the four questions, it is important for us to ask the fifth question. Okay, this is one thing, and the next that we can do is BSSA, that is brief suicide safety assessment question, that we can go ahead with. All these are a couple of questionnaires that we can ask to assess the client or the individual that we have. Now, means restriction. Um, has anyone, you know, has anyone actually read the news where in Kota they have put a mesh under the fan?
Yeah, this happened last year, I think. Last year or last to last year, this started
Yes,
floating on the
yes,
news. Yes.
yes. That's one thing. That is means restriction of means. As in, let's say, for example, if a student is hanging themselves, by restricting that, we are preventing suicide. Has anyone noticed that आजकल या स्प्रिंग्स यस स्प्रिंग फैंस ऑल्सो और आजकल ये बहुत ही बड़ा सोसाइटीज होते हैं ना लाइक प्रेस्टीज सोसाइटी फॉर एग्जांपल they are putting these green nets from the top floor. They're putting the green net so that people cannot jump, right? All of these they come under restriction of means, right? uh, yes, was there a question? Yes.
Does this help preventing suicide or not?
Okay. Restriction of means, it involves limiting access to the lethal means of suicide. Now, we cannot guarantee that if we do this, the person will not go ahead and carry on with the act of suicide. But as um, as an individual or as a society or as a mental health professional, we are restricting the means, limiting access to what can help them harm themselves. That is one of a strategy that we can use. Okay. Yes. Limiting access to sharp objects. Exactly. Yes. All of these. I'm really sorry. Just a second. Yeah. Now, all of these, they come under means restriction. Crisis intervention and follow up. What happens is crisis intervention, its services provide, the crisis intervention services, they provide immediate support and assistance for individuals experiencing suicidal crisis. It includes the hotline numbers that we have, the I call the Bandavella Foundation and the Telemanas foundations that we have. All of this, they come under crisis intervention. Now, follow up care and the support are very essential components for suicide prevention, which ensures that individuals, who receive ongoing monitoring and support, counseling, and access, a treatment they are following. Okay, I'll tell you what. Let's say, for example, yes, Kiran mental health helpline also. Now, follow up includes, let's say, for example, I know a person who's having suicidal ideations. I've referred them to a psychologist and I've told, yes, I'll be sending mail to every single person with the scales. Okay. Yes, as I was saying, the crisis intervention, what happens is, let's say, I have referred a client to go ahead and take therapy. Now, if I wasn't a mental health therapist, my role would not end in just referring. My role would still continue. I would still have to follow up with the person saying, hey, how are you feeling? How is the therapy working out for you? Are you taking medications on time? Should we hang out sometime? All of these. This, a person with a person who's a non-mental health professional can do. As a mental health professional, what we can do is sending a reminders to our clients saying, hey, I know that you have taken your first session or second session. How are you feeling? Are you doing your homework? Or are you seeing any improvement? When can we meet for a next session? All of that. Okay. Now, mental health education and awareness, while empathy and compassion, just showing empathy and compassion and being a bit of proactive in terms of, or in cases where we actually know that there are suicidal ideations involved. Okay. Now, I'm sorry. Coming to mental health education and awareness, providing a whole comprehensive mental health education and awareness for students. This is for school psychologists. This is in terms of school, for the whole students, for the teachers, the staff. Now, what do these programs include? They include information about the common mental health disorder, the warning signs of suicide, the coping skills, the resources to help. Now, how can we include this? How can we, do this? We can do this as a workshop for each and every single class, incorporating these topics in the whole school curriculum. This will actually help in creating awareness about suicide. Once the awareness about suicide is created, there are very high chances that the people, they even try to identify a warning sign, and they persuade the person to go for help. Okay. And promoting a whole positive school climate and connectedness, you know um, when we foster a very positive and supportive school climate, that helps in promoting the belongingness, and that also helps in building a resilience and connectedness among the students and the staff. Now what happens is, when we do this, we encourage the um, inclusive practices of being empathetic, and we encourage the practice of being kind to others, creating a space full of kindness, and also to create a sense of community and support, where a person will feel that if they have any problem, they could reach out to someone, and they could get help, that there is someone who can help them. Okay. Now, sorry. So this is what promoting positive climate and connectedness in school means. Now, suicide watch. How many of you understand? Okay. What do you think is suicide watch?
No, I don't know. This is the first time I'm hearing this term.
Okay.
Is it watching over somebody who feels suicidal, like making sure they're okay and constantly checking on them?
Yes. Yes. Exactly. Now, suicide watch, which is also in very common terms known as observing or monitoring, what it involves is very closely monitoring individuals who are at very high risk. Okay. When I say high risk, I mean high risk of suicide, to ensure their own safety and preventing self harm. Proactively watching, exactly. Now, individuals placed on suicide watch, I'll tell you, they may be monitored in a various variety of settings. It can I'm so sorry. It can include psychiatric hospitals, it can include emergency departments, it can include correcting facilities, rehabilitation centers, residential treatment centers, so on and so forth. Apart from that, it can also include checking up on them on regular intervals, checking if they're taking their medications or not, checking if they are eating or not. Okay. Trying to make sure that they at least try to follow a sleep regime, or they try to follow yeah. Thank you so much for that, but I don't know why my throat is acting up today. So yeah, as I was saying, they yeah, check, making sure if they have ate or not, making sure if they're at least trying to get some sleep. Now, lack of sleep is actually said to be one of the major warning sign that we see in terms of suicidal people. Okay. Can anyone help me understand how do you feel without a sleep of a day or two?
Irritation.
Perfect.
I'm not able to function.
Not able to function, tired, exhausted, and
Yes. Confusion.
physical
Lost.
fitness, uh, fatigue, burnout, all of that, right? Now, imagine feeling all of this and having suicidal ideations, right? That is one of the reason why lack of sleep is actually said to be one of the major warning sign in terms of suicide. Now, yes, suicidal watch, it can actually have sometimes what happens is, a psychiatrist, they would recommend one of the parent or one of the guardian to observe the person if they feel that they have suicidal ideations. Now, you may ask, how long should the suicidal watch be? Should I continue this for several months or several years? Since depression can show signs of excessive sleep and being sleep deprived, can both these be signs of the client feeling suicidal?
As long as the client is feeling better.
Yes. Oh, I'm so sorry. You were answering the previous question. Yes.
Yeah,
Yes,
like
yes.
for
As long
all
as the client is feeling better, we can go ahead with the, suicidal watch. Nivi, is it okay if I answer this question at the end of a session?
Sure, ma'am, sure.
Thank you so much. Now, the duration of suicide watch, it completely varies, depends on individual level of risk, their clinical status, and the response to the intervention. And to put it in very short terms, as long as the client is feeling better, I mean, if the client start feeling better, we can go ahead. We can stop suicidal watch. Are we clear?
But do we not still keep a check on any of the triggers, or maybe if a situation occurs where they can again go back to the
Uh,
suicidal stage?
I hear you, and I do understand what you say that we do keep a check. Yes, but the whole concept of suicidal watch is where we watch the or we closely monitor the person every 15 to 20 minutes. Now,
Right. Hmm.
that is different,
Hmm.
whereas monitoring the person is different,
Hmm.
right?
Hmm. Right. Yeah. Yeah.
I hope I hope you understood what I meant to say.
Yeah. Yes.
Yes. Yeah.
Hmm.
That is that. Now, not practice. Yes, we can check
Hmm.
up on the person regularly,
Hmm.
but
Hmm. Hmm.
not just being there. Suicidal watch, it also involves not leaving the person alone,
Person. Yeah. Okay.
especially at
Hmm.
nights. Um,
Hmm.
you do night duty, to be very honest. You be awake so that the person can sleep.
Hmm. 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 Hmm.
So that is suicidal watch.
Hmm. Hmm. Right.
Okay.
Keeping an eye is what suicidal watch is. What
Yes.
I was talking was keeping a check.
Keeping a check. Yes. Keeping
Okay,
a check
got it.
is different from
Yes,
keeping
yes.
an eye.
Right.
Okay.
Hmm.
Yeah. No suicide contract. Okay. The one thing that we have to understand is, yes, having a no suicide contract is always one of the safest practice that we can do. I agree to that. But what no suicide contracts involves is also known as a safety contract. It is also known as a crisis response plan. It is a written agreement between two individuals. Sorry, it is a written agreement between an individual who's at risk of suicide and their mental health provider or a caregiver. But no suicide contract is not legal. No suicide contract is just like taking a promise. Okay, let's say for example, I and Ashita, we both are having a conversation, and I say, Ashita, let's go for a lunch tomorrow. And she'll say, yes, yes, I promise you we'll go for lunch tomorrow. That is not legally binding her to go to lunch with me, right? In the same way, no suicide contract is like a pinky promise. Even though it is written, it's like a pinky promise.
can I add to the example?
Yes, yes, please, Ashita.
So now Sahiti has trust issues with me. So next time we go meet on a tissue paper, she makes me write a promise saying that next time we will fall. Ashrita will come for lunch with Sahiti at ABC restaurant at so and so time. What happens here is, though I have written it, though I have signed it and with Sahiti as the proof, again there is no obligation for me to follow. There's a very good chance where I may follow or I might not follow. Though it sounds very informal and it sounds very, like an agreement more than anything else. The reason why suicide contracts work is that once everything is written in physical reality, it at least it gives an opportunity for the person to have a second thought.
Exactly. Thank you
Mm,
so much for putting it in such an amazing way, Ashita.
thank
See,
you.
Instead of having a no suicide contract, what we can have is, you name it whatever you want. What you can do is, I name it as a hope kit. What I do in hope kit is, I have my therapist number, I have a couple of suicide helpline numbers, and I have photos of people that I absolutely love. I have photos of my memories that I can remember, and that always brings me joy, no matter where or what situation I am at. I have a couple of quotes that motivate me. To be very honest, I have a couple of songs, that just deviates my mind, and I have a couple of screenshots of messages where my friends have sent on how much they love me, my partner has sent on how much they love me, my parents have sent on how they're proud of me, all of that. It also, my hope kit, it also includes what triggers me and what coping mechanisms work for me. You can do this with your clients. Instead of naming it as no suicide contract, name it whatever you want. It include warning signs and triggers for suicide thoughts or behaviors. Develop coping skills and alternative behaviors to manage distress. Sorry, establish a whole list of supportive contacts and resources to reach out during crisis, and also agreeing to follow a specific steps. Like for example, I'll tell you, when I as an individual, it's coming from a personal example, when I as an individual, I was having suicidal thoughts. My go-to plan was cutting. What my therapist did was, whenever you have this thought of cutting yourself, take an ice cube, put it here. That was my, I would say, alternative behavior, right?
It also
Now,
calms your
these kind
CNS
of,
system down.
yes, exactly. Exactly. I do agree to that. Now, these are alternative behaviors. Um, I've I myself have actually suggested one of a technique to one of my client, where, you know instead of cutting yourself, or instead of eyes, you take a red marker and draw. That is an alternative behavior. All these should be included in a non-suicide contract. See, while a no suicide contract, it can serve as a very useful tool for promoting a whole collaboration between the individual and the mental health therapist, where we mostly look at the playing of an active role in the safety. It is very important to recognize that it has its own limitations. A contract alone cannot and will not guarantee safety. It will not guarantee prevention of suicide. And it should be, I would say, supplemented with a very understanding of comprehensive risk assessment. And there should be an ongoing support and access to every kind of professional care that the person requires. Are we clear?
Yes, I think.
Okay. Now, I know we are running out of time, but I really request you to be patient. Okay. Uh, yes, it's like a first aid kit. Emotional first aid kit. Yes, the rubber band also helps. Yes, thank you so much for pointing that out. People with suicidal ideations whose go-to plan is to cut themselves, mostly to, um, I would say, inject the pain in themselves. There is a rubber band that is there, and whenever they have the suicidal ideations, they do this. They do this. Took with rubber band. I'm not. I'm not flick themselves with rubber band. Okay, that is one alternative behavior. Now coming to assessment. Assessment. Assessment can be done through, assessment of individuals' current mental state, suicidal ideations, the risk factors, the protective factors. We can use standardized tools to assess if they are suicidal or not, and we can gather a proper MSc, mental state examination, and all of that. We can gather their previous medical history and all of that. All of these come under assessment. Now coming to safety planning. Safety planning is collaboratively with the individual developing a safety plan where outlining steps, as we have told, a suicide contract would work if, I would say, would be very helpful if we name it a safety plan, where which includes the times of crisis, the coping mechanisms, the support system that is there, where we could reach out to the contact information of emergency contacts, or the guardians contacts. Apart from that, the trusted individuals contacts, and the crisis hotline numbers, all of this. Now, crisis management. This involves removing of lethal means, contacting emergency services, contacting helplines, initiating the proper psychiatric evaluation and initiating of medicines, all of that. Psychoeducation, which also means creating mental health awareness, and you know educating the individual and their whole network about the risks of suicide, the risk factors of suicide, the warning signs, the coping skills, the resources available for help. Why is therapy important? Why is medication important? And why is it important to speak about suicide? All of this come under psychoeducation. And the next thing, counseling and therapy, utilizing evidence-based interventions like cognitive behavior therapy, DBT, or interpersonal therapy, all of this. And following up and monitoring, maintaining regular contact. Now, Gurleen, following up and monitoring is what we call as checking up.
Okay.
Okay.
Hmm. Thank
Hope
you.
that's clear. Yeah. Now, maintaining regular contact with an individual, following the crisis intervention and monitoring the progress, and just sending a very gentle reminders that you as a therapist are there if they need sessions. Okay. Now, apart from that, what else can be done in terms of I'm so sorry. Yeah. Apart from that, what else can be done is training and education. If you're working in school as a school psychologist, or if you're in school, providing a very comprehensive training for the whole staff members, including teachers, the school counselors, the school administration, the school IMs, as in the helper staff, on the warning signs of mental health, or the warning signs of suicide, and their the suicide behavior and everything. And apart from that, it can also include having a established support system in the schools, like having a school counselor, or I would say having the school staff being trained in gatekeeper trainings, all of that. That would also come under intervention. Apart from that, what else can come under intervention is collaboration and communication. You might ask, how can this is called intervention? Now, if we foster collaboration and communication between the school personnel, the parents, the caregivers, mental health providers, and the whole community that has, I would say, that are stakeholders of the safety of a child, if we have a communication with them, and if we break the stigma in the whole primary circle of a child, that would also help in creating a safe space for the child, in turn helping the child to reach out if there is any help, rather than looking at suicide as the only go to. Okay. Now, with this, we conclude the workshop. The floor is now open to questions. Now, Ashrita, are you here?
Yeah, yeah, I'm here. I'm here.
Thank you so much. Um, Now, I hear a question here. Since depression can show signs of excessive sleep and being sleep deprived, can both these be signs of the client being suicidal? Again, these both can be warning signs or risk factors. Again, the only way to understand if a client is suicidal or not is to directly ask the question. Or if you have seen any of a warning sign, what you can do is sit with the client and proactively form a safety plan. You can start by, or you can actually go for a proper assessment. I mean, assessment can, include. uh, going ahead with Kepler K10 questions or going ahead with ASQ. Now, you might ask, uh, you might feel that the client would, take it as an offensive way. "Arey, why are you screening me for suicide and all?" What you can do in that cases is you can actually use this script. This is what I generally use with my clients. I say, see, at my practice, I am very committed to my client safety. Many things, including mental health problems, can cause very emotional, distressing stage, sometimes leading people to have thoughts of suicide. Now, this questionnaire is very important because I just want to understand, and I am asking this question in terms. Okay, yeah. I'm just a second. I'm asking these questions by keeping your safety in mind. If you put it in this way, the client may agree to have a assessment done. Now, um, could you go into QPR framework a bit? Just want to know what the best way is to deal with an openly suicidal client in session. Anand, I hear you. QPR, the whole framework of QPR, it would generally take 2 to 3 hours to explain. But just to give a very, very brief about what QPR does is question, persuade, and refer, where you ask the question to the client and you persuade the client to go for help and refer the client to a therapist. The whole role of QPR gatekeeper, or the whole role of a person who is following QPR, is to only play um, a role where they understand the warning signs and they refer. Now, you yourself being a mental health professional, if you are, the way where you can go ahead is you can ask the person if they are okay with having the sessions with you, or if they want to have other persons, if they want to reach out to other person for the session. Are there any chances of relapse of suicidal thoughts? Nika, yes, there are chances of relapse of suicidal thoughts. So again, again, um, yeah. Now, coming back, what I was saying is, yes, there are chances of relapse of suicidal thoughts if there is no proper support that is there. There is no proper support system that is there. There is no proper safety plan that is there. There is no proper coping mechanism that is there. Now, let's say, for example, I'm a person who's having suicidal thoughts and I carried on with the act and I've survived somehow. Now, what happens is, if I don't go for therapy, or if I don't go for psychiatric evaluation, if I don't have a strong support system that is, that is there, that I can lean on to, if I don't have coping mechanisms with me, if I don't have safety plan with me, there are very, very, very high chances that I would have that thought again. I hope I answered your question. Um, Anyone else? This okay, so the webinar has ended as of now. Now, if you have any kind of questions, you can stay back.
Sahiti ma'am, with respect to the one that I had asked earlier, can excessive
Yes, yes.
sleeping also be a sign? Because in depression, that is one of the signs also. It's just not lack of sleep, right?
Yeah, yes, excessive sleep can also be a sign. Yes. Um,
All
so
right.
again,
Thank you.
if a person is actually clinically diagnosed with the clinical depression, having an underlying mental health condition, that is also a very great risk factor for suicide. I'm not saying that a person with depression will and must have suicidal ideations and they will and must have active suicidal ideations. I'm saying it is a risk warning, it's a risk factor. Okay.
Right. Thank you so much, ma'am. Loved your
Thank you.
webinar.
I hope I answered your question. Could you, okay, sorry, while discussing about interventions, what were the few therapies you mentioned? The few therapies that we can use is CBT, that is cognitive behavior therapy, DPT, dialect behavior therapy, interpersonal therapy, all of that.
Okay, okay, thank you. And also, I wanted to ask one thing. Um,
Yes, Guru.
I don't know how relevant that will be. But during the session, you mentioned once that a lot of times people go undiagnosed and they commit sorry attempt suicide. So
Yeah.
how do we get to know that they were going through some mental health condition? Does that come up in the postmortem?
Uh, okay. Oh my God, that's such an interesting question. And Gurleen, I would really, really want to appreciate the way that you consciously corrected yourself.
Uh,
Thank you. Thank you so much for that. Now, um, I'm not sure of the name. There is a series in Netflix.
mm-hmm.
11 people, the whole family hanged. House of Burari or something.
Burari
Yes,
model.
yes. Burari, Burari.
Yes, Burari. Now,
Okay. Mhm.
there is a concept called psychological autopsy. Now,
Hmm.
from my understanding, psychological autopsy is a proper, I would say, situation
Mm-hmm.
where people are trained by psychology, people are trained on how to conduct a psychological autopsy.
Hmm.
What this does is this is mostly a research tool. Okay, it involves collecting the data to completely, I would say, rebuild or reconstruct the whole psychological environment of a
Hmm.
person who has died by suicide.
Hmm.
Now, in this, what they generally do is
Mm-hmm.
they go ahead and they have conversations with the people. Let's say, for example, again, this phone has died by suicide.
Huh.
Now, what happens in psychological autopsy is whoever this phone has spoke with the last 6 months, the person who is
Right.
conducting the psychological autopsy will speak to them.
Hmm.
The places that they have visited, the activities that they have done, all of
Hmm.
this.
Hmm.
Now,
Right.
the whole goal of this is to actually understand the circumstance of death
Hmm.
and understand where has that thought or what is the reason for this having suicidal intent,
Right.
to understand what are the risk factors
Hmm.
and what are the warning signs that that the person has
Hmm.
shown, why were those missed and all of that.
Hmm. Okay. Hmm.
Now,
Makes sense. Huh.
in these situations, that is when we understand that okay, all of these signs,
Hmm.
they might match the DSM-5 criteria of depression.
Huh.
All these signs, they might match the DSM-5 criteria of anxiety
Something. Hmm.
or borderline disorder, anything.
Anything. Okay. Okay. Huh.
I hope this is.
Yeah. Yeah. So basically, while examining the person's history, they
Yeah.
sort of study what were the activities they were doing in the past few months to understand if this is something that is pointing to some underlying condition, to study
Yes,
the symptoms that were there. Okay,
exactly.
okay, that's interesting. Makes sense. Okay,
Okay.
thank you.
Thank
Yeah.
you. Thank you, Gurleen. Yeah, I really appreciate that how Gurleen corrected committed to attempted. Exactly. Exactly. See, I think it has been very deeply ingrained in our vocabulary that we use the word commit, but it is, I think it's the efforts that we put in, very conscious efforts that we put in to actually understand and change our terminology. And thank you so much, Gullian, for that. Now, sorry, if there are any other questions, I'll be the